introducing Dr. Yasser Suleiman, Vice Dean of Faculty of Medicine, Ain Shams University, and the Professor of Nephrology, talking about immunology of kidney transplantation as preparing our program of renal transplantation in EgyptAir Hospital.
Thank you. Bismillah ar-Rahman ar-Rahim. I'll talk today about an introduction about the immunology of kidney transplantation. Kidney transplantation is a treatment of choice for end-stage renal disease, as there is reduced morbidity by improvement in quality of life, return to work, reduced hospitalization rates, and also there is mortality advantages, reduced cost to the health care system, and lastly, female fertility. Graft prognosis, as we know, that graft survival is affected by whether the donor is cadaveric or living donation. The recipient of cadaveric kidneys have more episodes of rejection and lower graft survival rates than those with living donation. Again, the patient survival or mortality, survival of patients after transplantation from living donors is 98% in 1 year compared to 95% in case of cadaveric. The preemptive transplantation of kidney from living donors. Preemptive means the donation or transplantation before the commencement of regular hemodialysis. These donors associated with improvement in allograft survival. We want to know rapidly some definition during the introduction in order, because this terminology repeated during this lecture. As we know, all the gene means DNA sequences that encodes a specific protein, allele, an alternative of different form of gene. Haplotypes, this is expressed allele on one chromosome, one haplotype from each parent. Genotypes, the sum of two haplotypes. Polymorphism, many allelic types within a species. And allotypes, antigenic determinants that differ among individuals of the same species, such as the epitopes of the Rh blood group system or epitopes of the HLA system. Histocompatibility or transplantation antigens, these antigens on tissues and cells that determine their rejection when grafted between two genetically different individuals. There is a major histocompatibility antigens. Histocompatibility antigens that cause a very strong immune response and are most important in rejection. And in human MHC complex, the antigen is on the surface of the cell, as you see here. The complex, this means genes on a single chromosome encoding this MHC antigen. In human, it's termed HLA. As you see here, the types of grafting. This is isograft between identical twins, and there's autograft to the same individual, for example, skin grafting. Allograft, different individual but same species, and lastly, the xenograft between two different species. The terminology of grafts, types of grafts, is xenografts, heterologous, or xenogenic, or heterografts, while allograft, also named as allogenic or homograft, and lastly, isograft, grafts between members of same species with identical genetic makeup. Autograft, graft from one individual to itself. An immunocompetent host recognizes the foreign antigen on graft tissue or cells and mount an immune response which result in rejection. On the reverse, on the other hand, if an immunocompromised host is grafted with the foreign immunocompetent lymphoid cells, the immunoreactive T cells in the graft recognizes the foreign antigen on the host tissue, leading to damage of the host tissue. This is very simple, as we know all, that donor, if there is the same antigen, it will accept the graft. If it is a different antigen, will reject the graft. The duration of graft survival follows the order that it is best in autograft and also the isograft. Less than in allograft, and it's worse in xenograft. The time of rejection also depends on the antigenic disparity between the donor and the recipient. MHC antigen are the major contributors in rejection, but the minor histocompatibility antigen also play a role. And rejection due to disparity in several minor histocompatibility antigens may be as quick or quicker than rejection mediated by MHC antigen. As in other immune response, there is immunological memory and the secondary response in graft rejection. Thus, once a graft is rejected by a recipient, a second graft from the same donor or a donor with the same histocompatibility antigen will be rejected in a much shorter time. We'll talk very rapidly about the graft versus host. This condition known as graft versus host, as I said before, when a donor with immunocompetent cells here donated to an immunocompromised animal with total body irradiation, these immunocompetent cells will act against the host antigen, leading to death of the recipient. Common manifestation of graft versus host reaction: diarrhea, erythema, weight loss, malaise, fever, joint pain, etc., and ultimately death of the patient. This is graft versus host disease. This is vivid palmar erythema, is chronic state of graft versus host with hyperpigmentation in the back, and this is lichenoid in the skin, and this is buccal mucosa erosions in graft versus host in acute state. The role of HLA in transplantation immunity. In order to appreciate the role of HLA in transplantation, we must first consider the structural and the functional aspect of HLA molecule. HLA antigens are controlled by a series of highly polymorphic genes on the short arm of chromosome number 6, known as MHC. As I said before, the antigen on the surface controlled by a gene on the chromosome. The most important thing, it is a co-dominantly expressed. Once the gene is present in the chromosome, it will appear as an antigen on the surface, whether maternal or paternal, in a co-dominant expression. To simplify the nomenclature of these sites or loci, in class 1, there is classic class 1, HLA A, B, and C, and the non-classic, which is E, F, and G, and lastly, class 1 like the MICA and the MICP. Now, classic class 2, it is more complicated in class 2. Why? There is also 3 letters in class 2. Why? Classic and non-classic, like class 1, and then the first G for the class, and the second M, O, P, Q, R, D, R, D, Q. This is the family, and lastly, the third is the nomenclature for the chain, alpha chain or beta chain. This is the chromosome number 6. In the short arm of chromosome number 6, as you see here, it is arranged class 2, MHC, and class 3, this is out of this area, or if it is related to the inflammatory process, and this is class 1. To magnify class 2, here it's present, arranged the loci as I mentioned before. And this is the class 1 in magnified manner. This is class 1, it's very simple. Why? Because it's only the alpha chain present in the chromosome number 6, B, C, and A. While class 2, there is alpha chain and beta chain. This is DB, DQ, and DR. Class 1 gene expressed by most somatic cells اللي هي nucleated cells. This means that in the RBCs is out of this area, while class 2 is more specific, present expressed by subgroup of immune cells, antigen presenting cells, dendritic cell, B cells, activated T cells, macrophage, thymic epithelial cells. Other types of cells can express class 2 HLA molecule in the presence of interferon gamma. Now this is the diagram showing the class 1 antigen formed of alpha chain and beta chain. This alpha chain formed of 4 separate regions. This is peptide binding site or region, immunoglobulin-like region, and then transmembrane, and lastly cytoplasmic tail. This beta chain is not crossing into the cytoplasm. This diagram for class 2. As you see here, there is alpha and beta chain, both crossing the cytoplasm into the intracellular part or cytoplasmic region. This diagram shows the difference between class 1 and the class 2. Class 1 alpha chain is out and going down into the cytoplasmic tail, while beta chain remain outside. In case of class 2 antigen, both alpha and beta chain go inside into the cells. Class 1 alpha present in the chromosome number 6. Class 2 alpha and beta present in chromosome number 6, while the beta chain present in the chromosome number 15 is the beta 2 microglobulin. This is the HLA polymorphism. As I said before, there is increase in the number. About the nomenclature of HLA specifics are identified by a letter for locus and a number for the loci, A1, B5, and so on. And the haplotype are identified by individual specificities like A1, B7. This is a set of 6 loci. Specificities which are defined by genomic analysis, BCR, remain are names with the letter for the locus and the 4-digit number as you see here. 4-digit designation for the nomenclature by the PCR. The antigen designation makes up the first 2 digits. The sequential allele designation makes up the 3rd and the 4th digits. The presence of asterisk to indicate the typing was performed by DNA methods. For example, HLA-A1, HLA-A0101. This is how to nomenclature. This site is the site which is called IMGT, which is immunogene ticks, shows that any recent detected genes or loci, which is very rapidly growing. As you see here, in 2011, it was in class 1, 4,009 alleles, class 2, 1,004. In 21, there is an increase to 23,000 allele for class 1 and 8,000 for the class 2. This is the rapid growth in the detection of alleles, whether class 1 in red or class 2 in yellow. And this is in 2024, which reached class 1 reaches 28,000 alleles, and the class 2 about 8,000 to 12,000 alleles. About the inheritance of these genes, the MH genes are inherited as a group of haplotype, one from each parent. One set taken from the father and the other set taken from the mother. Thus, heterozygous human inherit one paternal and 1 maternal haplotypes. A heterozygous individual will inherit a maximum of 6 class 1 specificities. And similarly, the individual will also inherit DP, DQ genes and express both parental antigens. Since class 2 is more complicated, it will consist of 2 chains, alpha and beta chain, with some antigenic determinants, specificity on each chain, and the DR alpha and the beta chain can associate either in cis. Cis means that both chains are taken from one parent, or trans, one from each parent. Combination, and the individual can have additional DR specificities. Also, there are more than one functional DR beta chain gene, hence many DR specificities can be found in any one individual. As you see here, this is cis, means alpha and beta chain taken from the same parent. Trans, alpha taken from one parent and beta from the other parent. There is no problem about the class 1. As you see here, there is only alpha chain. Again, this is another complication occur or lead to more polymorphism, what's called crossover. As I said before, one haplotype taken from each parent. Sometimes part of the haplotype is taken from one parent and the other part taken from another parent. As you see in this middle, this what's called crossover. One set is taken from each parent, while this down show the crossover. As you see in red here, this one locus from one parent and the rest taken from another parent to form this haplotype, which is called crossover. So how to detect this antigen or MHC, either serological or more recently by PCR or the use of monoclonal antibodies. The main purpose of tissue typing, as you know, to assess donor-recipient compatibility for HLA and the APO, to analyze patient serum for antibodies that react with transplant donors, tissue typing for clinical transplantation. Most relevant is the cross-match assay, whereby patient sera are tested for their reactivity with the donor lymphocyte. This is usually done by immune lymphocytotoxicity testing. A positive cross-match is a contraindication for organ transplantation because of the risk of hyperacute rejection and the higher incidence of vascular rejection during the early post-transplant period. Modification of this testing, there is anti-human globulin augmentation, flow cytometry, ELISA technique, B-cell cross-match, and lastly, virtual cross-match. Virtual cross-match, this means that the computer will do this cross-match, not actual cross-match with the serum and cells, whether cellular or for antibody positive cross-match. This is happen usually in the cadaveric donation, for example, in the States or Europe. There is a set of tissue typing for the recipient, and once there is a donor in another country or in other states, will do virtual cross-match, will help them to choose which is the best couple for transplantation. Now generation of cytotoxic T lymphocytes, as you know, the CD8 cells must be activated to be a cytotoxic. First there is a mitosis and then change it to cytotoxicity, and lastly to attack the cells. I'll show it in the diagram better. Now, this is class 1. Sorry, the laser is not working well. This is class 1, this is class 2, this is combination of class 1 and 2. In order to occur mitosis in the CD8 cells, it will be occur by class 2 MHC. In order to change into a cytotoxic CD8 cells, it needs both class 1 and the class 2 MHC. In order to identify or recognize the targeted cells, it needs class 1 to attack it. Okay? In order to occur mitosis in the CD8, it needs class 2. In order to be changed into a cytotoxic T cell, it will identify both class 1 and class 2. In order to recognize the cells to be attacked, it needs class 1 MHC. Now the panel reactive antibodies that transplant candidate may become sensitized following prior transplant, blood transfusion, or previous pregnancies. The BRA can vary between 0, non-sensitized, to even 100%, indicating a high degree of sensitization. Patients with high PRA values are less likely to have cross-match negative donors. They must wait much longer for a transplant, and some may never receive a kidney at all. Antibodies against donor antigen called donor-specific or DSA, and we are using now the Luminex assay to know the single. Before, the PRA mentioned in percent, 80%, 70%, which antigen, I don't know. But now the single antigen will detect the antigen which PRA is against it, okay? And that's why we can detect the donor-specific antigen before transplantation. This mixed leukocyte culture, MLC, alloreactive T lymphocyte, are primary mediators of cellular rejection. This MLC is an in vitro system that determines T cell alloreactivity between donor and the recipient, and done in the lab. But since these MLC procedures are technically demanding and time consuming, they are not routinely used for prospective histocompatibility testing in clinical service laboratory. Now what about match and mismatch? While the HLA system comprises multiple class 1 and specifically class 2 genes, most matching strategies consider only 3 loci. In class 1, A and B, and the class 2, you are using DR. Although it makes sense to define a perfect match for each transplant patient, the reality of clinical practice dictates the selection of less well-matched donors. As noted above, current strategies are directed towards the identification of donors with permissible or for donors with permissible or acceptable HLA mismatch. For example, here, this is on the left, this is the recipient, and this is on the right, the donor. As you see here, the loci, similar, matched. This means 2 in class 1 and 1 in class 2. This means the match is 3/6 matched, mismatch 3/6. Another example in between, again, sister and brother. There is matching in the DR loci. Okay. Now the list acceptable matches في اللجنة العليا عندنا دلوقتي there must be 1 match in the DR looks. This example is very important. As you see here, this is the recipient and this is the donor. When we see the matching, this means that the matching is 2/6 and the mismatch 3/6. If we reverse, suppose the reverse. This is the donor and this is the recipient. The match is also in 2 loci and the mismatch in 3. This means that the matching is 2/6 and the mismatch 3/6. What's the difference between both? The first example is better. Why? There is no mismatch in the DR. Okay? As you see in the previous example, matched in both DR, this is better than the presence of mismatch in DR, again in match in class 1. After the transplantation and what's called the clamping and the blood flow into the grafted kidney, we will start the immunology of what happened? How does the immune system deal with the transplant? What are the mechanisms of rejection? What are the current clinical strategies to block this rejection? And what are the new and future strategies to promote specific immune tolerance? Just I know to remember that helper T CD4 cells recognized by bound to class 2 MHC gene products, and cytotoxic T, as I told you, CD8 cells recognize peptide bound to class 1 MHC. Immune response against transplant depend on the presence of antigens in the grafted tissue that are absent in recipient and absent and hence recognized as foreign non-self. This is the process: antigen presentation followed by antigen identification or recognition, then immune activation. Once immune activation occurs, there is amplification of immune activation, leading to direct graft cytotoxicity, antibody-mediated mechanisms, and the inflammatory reaction. All these mechanisms will act to cause rejection. Starting by allograft recognition and the co-stimulatory pathway in the T cell. This is the first step. As you see here, this is the antigen presenting cell, this is the antigen, and this is the T lymphocytes. There is two pathways for antigen recognition or identification. Either direct. In case of direct, the antigen presenting cell is the donor presenting cells. That's why in blue. In case of indirect recognition, the antigen presenting cell is the recipient antigen presenting cells. As you see here again, this is the recipient antigen and this is indirect, while in case of direct, this is the donor antigen presenting cells. What's the difference between direct and indirect? In case of direct, the antigen presented as it is. But in case of indirect, the cell will take this antigen, lead to processing this antigen, and reintroduce it or part of it into the T lymphocytes. What's the importance of this? The mechanism of direct recognition usually occur in acute rejection, and that's why it is a vigorous reaction. While in case of indirect recognition, it will cause chronic rejection, which is slightly weaker. This is the steps of T cell activation. As you see here, this is signal 1. Signal 1 is provided by the recognition of antigen by T cell receptor, TCR, while signal 2 is provided by ligation of CD8 and inducible co-stimulators by the reactive ligands. Signal 1 and 2 leads to activation of T cell and the expression of interleukin 2 receptor, and the CD4L. In the middle one, the memory T cells don't require co-stimulatory pathway through the CD8 to become activated. Co-stimulation through the inducible co-stimulator is sufficient. Okay? The last one in the right show absence of B 7 or blocking of B7, absence or blocking of B7 to be blocked by, for example, CTLA, immunoglobulin, IgG, lead to what's called energy. The cell become energetic, not reactive at all. CTLA ده اللي هو البلاتاسيبت. This is signal 1 and the co-stimulation, and then lead to transcription of the interleukin 2 and the interleukin 2 receptor, and lastly signal 3 through the target of rapamycin, ending in all the T cell proliferation. Once the antigen detected, the T cell go into the with the antigen presenting cells in the secondary lymphoid organs, and leading to this process present down here, signal 1 and signal 2, leading to transcription of interleukin and interleukin receptor, and then signal 3 through the emitter, leading to nucleotide synthesis and the cell cycle, leading to cellular proliferation. Antigen binding induces a conformational changes in the TCR complex. These through phosphorylation and coupled via G binding protein to phospholipase C. The activation of phospholipase C results in production of inositol triphosphate. Again, intracellular calcium increase. Nuclear factor of activated T cell is activated by dephosphorylation, and lastly production of messenger RNA or interleukin 2. This is, as I mentioned, the phospholipase C with the production of inositol triphosphate, influx of calcium, increase intracellular calcium, and through the effect on calcium, there is a change or activation of inactive neutral factor of activated T cells, which go intranuclearly to activate the production of interleukins or cytokines and the interleukin 2 receptors. Once the T cell is activated, it will activate the cells which activate it, which is the antigen presenting cell, and there is a vicious circle of activation between both the T cells and the other to what's called firing the immune system. As you see here, this is the antigen presenting cells activates the T cells through the TCR and the co-stimulation, lead to production of stimulators to the T lymphocytes, and the T lymphocytes will activate also the antigen presenting cells. Again, the activation, as I told you before, the CD8, which is a cytotoxic T cells. These cytotoxic T cells, as I told you before, need CD4 and antigen presenting cells. This means class 1 and class 2 to be activated or to be cytotoxic cell, and then will attack the graft and attack the class 1 MHC. What happened by cytotoxic T cells? It will lead to what's called perforin, which lead to cell lysis and the production of granzymes, which also lead to cellular apoptosis. This shows the whole mechanism, which is started by activation of antigen presenting cells to the T lymphocytes, and then will produce T helper 1 and the pathway of cell-mediated cytotoxicity, antibody-mediated cytotoxicity, and lytic damage by antibody mediated with complement activation and inflammatory pathways leading to graft destruction. This fired immune system must be something to control this fire, and what's called the negative selection of CD8, which is called T regulatory cells. These T regulatory cells can inhibit this fired immune response. Very simplified types of graft rejection. Each one of these will need a lecture to be talk about it, and there is classifications for this type of rejection. There is hyperacute rejection and accelerated, which occur due to preformed antibody donor antibodies and the complement, and accelerated rejection, reactivation of sensitized T cell, acute rejection, and lastly chronic rejection. I want from you to ignore this accelerated rejection, but it is present in the old paper. There is no accelerated rejection in the new classification of types of rejection, which is called BAMF classification. Hyperacute rejection occurs within minutes or hours due to an incompatibility between donor and recipient, where recipient has been sensitized against the donor histocompatibility antigen, must not occur. مش مقبول انها تحصل خالص. حاجه اسمها hyperacute rejection دي مش مقبوله خالص. By previous pregnancy or blood transfusion. يعني ده بيبقى عنده positive cross match. Means hyperacute rejection means that this patient already have antibody preformed antibodies or positive cross match before transplantation. On table, you must do nephrectomy for the graft. Acute rejection. Various classification categorized according to the timing, whether early acute rejection within first 6 months or late, more serious occur after 6 months and up to 5 years. Or the nature into 2 types, cell-mediated rejection or cellular rejection, and lastly antibody-mediated rejection, or another term is vascular rejection. As you see here on the right, this is arterial lesion, means antibody-mediated, and to the right this is the interstitial lesion, cell-mediated rejection. Chronic rejection, the boundary between acute chronic rejection is not clear. Biopsies show features of both occlusive vascular changes may be seen as early as 10 days after transplantation. مش معنى chronic rejection معناها late. أحيانا بتبدأ بدري, very early after kidney transplant, and it is irreversible. As you see here, this is picture of chronic rejection. Now, after transplantation, current approach to drug therapy in transplantation, where and how different immunosuppressive drugs act. The clinical goal to prevent or treat acute allograft rejection when it occurs, to improve long-term graft and patient survival. Second, to minimize the toxic effect of immunosuppressive regimen and avoid infections or complications due to oversuppression. Actually, it is a critical balance. If you over immunosuppress the patient, it will lead to toxicity, infection, and malignancy. And if it is under immunosuppressed, there is the increased possibility of rejection to occur. About prophylactic, which means that it's given after transplantation and lifelong for maintenance, decrease the incidence of frequency of rejection. The available medication, MMF, cyclosporin, azathioprine, tacrolimus, steroids, serums, and platacept. Now, the reversal therapy resolves the acute rejection episodes by short-term administration. They are added to the existing prophylactic immunosuppressive regimen until resolution of the acute rejection episodes. Either first line reversal therapy is usually intravenous steroids, while second line, which is polyclonal as HEG and LG, and sometimes monoclonal antibodies, almetuzumab, Cambas, or rituximab, which is MAPS here. Now the induction therapy. Inductions means using the reversal agents in a prophylactic setting at or around the time of surgery, for the first few days following the transplantation days, the first onset of rejection. Now, for example, the ATG, ALG, OKT3, which is monoclonal antibody, and the daclizumab, basiliximab, اللي هو اسمه Simulect. This is interleukin 2 receptor and blocker. Almotuzumab, which is a campus, and rituximab, which is Mabsera, and obinutuzumab, which is Gazyva. Induction may also be used to delay the first dose of CNI. As we all know, that CNI always has a nephrotoxic effect. And after transplantation, immediately there is increased possibility of DGF or delayed graft function, and that's why the use of induction make us to delay the start of CNI after transplantation. As I mentioned before, this is the various steps of signal 1 and signal 2, and then signal 3, and lastly the activation of cell cycle. And here to know the site of action of each immunosuppressive drug. We'll start by the first step, which is identification or recognition. Once recognition, this means the use of antibody, OKT3 monoclonal antibody or OTG, to act on the TCR or CD3. Okay. Then the signal 1 through the cyclophilin or FK binding protein, the action of cyclosporin A and FK, which is the tacrolimus. Here, the action of cyclosporin on cyclophilin and tacrolimus on the FK binding protein to inhibit the signal 1, leading to inhibition of activation or prevent the activation of nuclear factor of activated T cells to active nuclear factor of active T cells, and that's why we'll hold very early the immune response. Now, this is the co-stimulatory pathway or signal 2. This is the site of action of belatacept, which is the TLA4 IgG. Next, this is the signal 3. Signal 3, after cytokine receptor stimulation or interleukin 2 receptor, there is an mTOR. This mTOR, or target of rapamycin, the rapamycin will inhibit this signal, and this means that this is the site of action of sirolimus and everolimus. Now, this is the antimetabolitic effect of this group. First is the MMF, اللي هو Cellcept or Myfortic, will act in the inositol monophosphate dehydrogenase, inhibiting the formation of guanosine monophosphate. The azathioprine act on the same, but it is has different action, more than this effect acting on the adenosine deaminase, and that's why the azathioprine may have more side effects than the MMF in this location, in addition to action in the xanthine oxidase enzyme and its complication with the use of allopurinol. Now, this is signal 1, as I told you, blocked by monoclonal antibody, this receptor, and this is the site of action of cyclosporin. Okay. Co-stimulation inhibited by belatacept. This is the site of action of steroids, which prevents the transcription of this messenger RNA and interleukin or all cytokines. Again, this is the signal 3, whether you inhibit the receptor by monoclonal antibody, as I told you, daclizumab and basiliximab against the interleukin 2 receptor, or everolimus and sirolimus will act on the mTOR, and last here the mycophenolic acid, MMF, will act in the nucleoside, and lastly the azathioprine act in the cell cycle. This is the steps diagrammatically, and this is the site of action of glucocorticoid ending in cellular proliferation. Now, what about general mechanism of action of immunosuppressive antibodies? Non-selective depletion of lymphocytes زي HEG والcampus وريتوكسماب, or altered signal and lymphocyte trafficking the anti-CD3, anti-adhesion molecules and CTLA4 IgG, and lastly inhibition of interleukin-2 receptor daclizumab and basiliximab. This is all the immunosuppressive medication available to be used. This graph is very important. الحقيقه يعني ما فيش محاضره تتقال على الاميونوسبريسيف ميديكيشن بالنسبه للكدني الا لازم الجراف القديم ده يتقال. ليه؟ عشان نشكر اللي اكتشف السي ان اي اللي هي عمل السيزورينج للجراف ده، خلت very marvelous improvement in 1 year survival, as you see here, from 40 to this scissoring to be reaching 90%, and the decrease in the rate of rejection episodes occurring in the first year post-transplantation, as you see down here. Now, to categorize the immunosuppressive medication, either induction, steroids, anti-HEG and interleukin-2 receptor, or the maintenance like corticosteroid, CNI, mTOR, antimetabolite, belatacept, and the treatment of rejection by corticosteroid, anti-sinusoid globulin, plasmapheresis, intravenous immunoglobulin, rituximab. And this medication used in the treatment, or immunosuppressive medication used in the treatment of rejection, is similar to those used in the desensitization. Desensitization, as I told you before, patients sensitized before transplantation in order to override the presence of panel reactive antibody or donor specific antibody before transplantation. This is, again, to conclude, the immunosuppressive medication either minimize the histoincompatibility between the recipient and the donor by HLA matching and the prevention of monokine production by corticosteroids, and listed various drugs I mentioned before. What about, very shortly, about the available immunological tolerance mechanisms? Transplantation tolerance is a state in which there is a lack of destructive immune response by the recipient toward the well-functioning donor organ. خدوا بالكم الشروط. أول حاجة يبقى well-functioning donor organ in the absence of maintenance immunosuppression and with a fully intact immune system. يعني ما أقولش إن ده عنده immune tolerance لو حصل له any disease affecting his immune system, whatever affecting the response. This is what's called the immune tolerance. To improve transplantation outcome, it is critically to continue development of novel strategies to prevent acute and chronic rejection while lessening the need for lifelong immunosuppression and promote the development of a state of donor-specific tolerance. There are anecdotal reports of renal transplant recipients who either through non-compliance or as a result of malignant complication have ceased taking all immunosuppressive agents, yet have failed to reject their allograft. I didn't see this immunological except in 2 patients, both for non-compliance. The immune system, or what's called tolerance, either affecting the primary lymphoid organ, bone marrow and thymus, or secondary lymphoid organs, lymph node and spleen, and lastly the graft itself. This is the central tolerance here, and this is the peripheral tolerance through the effect of acting on the co-stimulatory blockade by belatacept I told you before, this leading to energy of the cells, or activated induced cell death, again through co-stimulation, and lastly by T regulatory or effector cells leading to immunosuppression. This is the mechanism in immunological tolerance, either intrinsic by ignorance or energy or phenotypic skewing or apoptosis, and or extrinsic through the what's called the tolerogenic dendritic cells or regulatory T cells. This is the ways of tolerance or induction of tolerance through lymphocyte depletion, co-stimulation blockade, Tregs, total lymphoid irradiation, thymic manipulation, or microchimerism or chimerism. How this is a CD4 Treg cell will act, leading to on the antigen presenting cells, leading to suppression of its action, the action of CD4 or the CD8 effect on it. This is the FOXP3, the site of its action. Inhibit the naive T cells to be an effector T helper 1 or T helper 2, leading to this cell inactive, inhibiting autoimmune disease, allergy, graft rejection, inflammatory bowel disease, or other immune response. This is the site of action of this FOXP3. The balance between the effector and the regulatory function of the immune system dictates the outcome of the immune response. If there is increase in the regulatory cells and the suppressor factors lead to tolerance in the graft. If there is the effector T cells clone size increase leading to the rejection. This is a balance between both sides. The risk of infection and aplasia and ultimately this associated with the actually available conditioning regimens significantly outweigh the potential benefit of tolerance in solid organ transplantation. And this tolerance can be broken by new clones of T and B cells appear in the absence of antigen. Viral infection can create a cytokine milieu to turn on quiescent energetic cells, and new epitopes are introduced either by viral modification or iatrogenically. Approximately all cases of clinical operational tolerance have been reported mainly in patients who were not compliant, as I told you, with their immunosuppressant regimen, or individuals who had previously received a bone marrow transplant for hematological disorders. In conclusion, stable clinical operational tolerance after renal transplant remain an elusive goal, and the different strategies attempted to date are not yet reproducibly safe or effective. And this is the best seen during transplantation, that the kidney will give urine after transplantation. And thank you.
شكرا يا دكتور ياسر على المحاضرة الجميلة دي والتقيلة طبعا يعني.
Any question؟ يا اما سهله قوي يا اما محدش فيهم حاجه خالص.
مش سهله خالص.
شكرا.